So the thyroid gland is an organ that sits at the bottom of our neck. It's a bit like a butterfly-shaped gland, and in a normal, uh, non-enlarged state, you can't really feel it. And its function is to control the metabolism in our body. So in effect, it sets the rate of how hard the body is going to work in terms of the brain and the gut and the heart. So as long as it's got a good supply of iodine and it's working well, it should act normally by having a feedback mechanism with the brain and the chemicals released from there. It's in fact a very clever organ in that sense. Often patients come to me not knowing that their thyroid function is off, but when you probe, there are certain key indicators suggesting that the thyroid function is low or high. So for a low level of thyroxine in the body, patients will often suggest that their weight is going up. They might feel bloated. They might feel a bit lethargic and sleepy. They might feel that they're a little bit sensitive to the cold. But one of the problems the clinician faces is that those sorts of symptoms are often present in patients with a normal thyroid function. So it's imperative to get a blood test to know exactly where the thyroid function stands. And of course, the other way, in effect, it's very similar, but opposite symptoms. So when the thyroid function is high, when there's too much thyroxine running around the body, patients can feel hot, they can lose weight, their pulse, their sort of resting pulse can be high, they can feel palpitations, they might feel sweaty, that sort of thing. So thyroid lumps in themselves are pretty common. We see thyroid lumps, particularly in women, and as one gets older, the natural degenerative process can mean that little nodules appear. And some of these you can't feel, and as they get bigger, you can feel them with your fingers. But occasionally we do come across thyroid cancers, and it's quite important to differentiate between a lump that's a cancer and a lump that's just what we call a colloid nodule. Of course, there are other causes of thyroid lumps, and sometimes we see patients where a particular nodule, a dominant autonomous nodule, is producing lots of thyroid hormone. So referring back to what I said earlier, when the thyroid function is high and there's one little nodule that's pumping out all the thyroxine, that can happen too. So as with many lumps in the body, the primary concern is to understand which ones are benign, that's not cancerous, and which ones are cancerous. And cancers throughout the body occur because of deregulation of a normal cell cycle. So cells normally die off, replicate, but due to external factors, due to genes, and in thyroid cancer, the risk factor, most of them, we never really know why it's happened, but genetics certainly plays a part. And smoking and exposure to radiation, as we saw in eastern Poland and Ukraine after Chernobyl, all plays a part in deregulating the cell cycle in thyroids, causing thyroid cancer. So there are several reasons for surgery. Of course, there are the patients where there may be a cancer, or we've ascertained through testing that there is a cancer, and those patients will, of course, need surgery to remove that cancer in the form of either a half or hemithyroidectomy or a total thyroidectomy. Sometimes there are other parts of the operations associated with that. But cancer is not the only reason why people have thyroid surgery. Sometimes patients will have one particular nodule on one side that's pumping out lots of thyroxine, and they're not appropriate to have radioactive iodine, and they need surgery. Sometimes a large multinodular goiter goes down in the chest or gets very bulky and pushes on the airway. Those patients need surgery. Sometimes patients will come to me and say there's a lump and it's pressing. And if I'm convinced with the patient that that's the cause of the compression, that's causing enough detriment to their quality of life, then that might be a reason for surgery. So I think it's imperative not to jump into surgery, but the judicious use of surgery is important once we've ascertained what the issues are. So thyroid surgery is safe surgery. However, there are associated risks. In my NHS group, we do the second most number of thyroids in a trust in the country. So we're very experienced in it. But nonetheless, all surgery has potential risks. And of course, there are the generic risks with any surgery, such as bleeding, infection, a small scar in the lower part of the neck. But then there are the specific ones with thyroid surgery. Now, of course, if you take all of the thyroid away, you will 100% need to take oral exogenous or tablet form levothyroxine forevermore. If you take half of the thyroid gland away, it's about a 10% chance that you'll need to take that. And we tend to test after a couple of months and see if your thyroid levels are low enough to warrant it. Now, of course, there are some important nerves that lie behind the thyroid gland. And often before, well, always before surgery, we will check that the vocal folds are moving so that we know that this nerve, that the important nerve that's going to the voice box is intact. So it's the recurrent laryngeal nerve that allows the vocal folds to move. So by passing a little telescope into your nose before the operation, we can see if the vocal folds are moving. And it's throughout the operation, we use something called a recurrent laryngeal nerve monitor to ensure that we don't damage that nerve. We quote the chance of nerve damage as being less than 1%. And now, of course, so if you were to have a recurrent laryngeal nerve injury, it's a very important nerve. You would end up being quite hoarse, but usually the other side will compensate. There's a more commonly injured nerve, and part of the reason for that is that often it has to be taken as it's running in the thyroid gland, and we often have to take all of the thyroid gland, and that's the superior laryngeal nerve. And that's a nerve that causes pitch, or when it's intact, allows you to pitch, elevate, and throw your voice. So for a singer or a teacher, it's incredibly important. And I, for one, always look for that nerve and try to preserve it. But it's a much more commonly affected nerve. Now, of course, there are the parathyroid glands, which you may have heard of, and those are not the thyroid glands. They're like a grain of rice, and there are 4 of them, and they sit behind the thyroid gland. And in a total thyroidectomy, it's crucial that we keep these parathyroid glands intact with a blood supply. And the reason for that is that they're very important in calcium metabolism. And it's very important that these work afterwards. So we do monitor your parathyroid hormone levels and calcium levels afterwards, as in the immediate post-operative period. It's important your calcium doesn't drop quickly. But in a proportion of patients, in my experience, particularly patients that are having surgery for diseases such as Graves' disease, which I didn't mention earlier, an autoimmune disease requiring the thyroid to be removed, they're more likely to be damaged, which can be problematic, and patients will need to take calcium and potentially vitamin D supplements. Well, patients tell me it's pretty good in the sense, I would say 95% of patients leave the hospital the next day. Everybody in my practice stays overnight because of the risk of bleeding. So we leave a drain in, but we wouldn't want a collection in the neck. So we keep everyone at least one night. But if the drain is still producing a little bit of blood, then we sometimes keep people a second night, but that's relatively rare. Patients don't find it particularly painful. It's clean surgery. So infections unlikely. We don't usually give antibiotics. Patients will often be a little bit concerned that if they move their neck a lot, it might splay open the wound, but I've never seen that. And actually, the fear of not moving your neck means that the muscles at the back of the neck sometimes get quite tight and uncomfortable. So I tend to recommend my patients do move their neck regularly after surgery. Of course, the recurrent laryngeal nerve is almost always completely intact, so that shouldn't cause a bother. If it did cause a bother after surgery, immediately when the patient wakes, they would have potentially a hoarse voice, and when they drank water, they may cough. After, I would say, 2 days in my practice, 48 hours, sometimes 3 days, we remove the clips. And people often say, well, that's a bit early. That can't be the case, but we've found in our practice that we have excellent cosmetic results by doing that. I would say that 2 weeks off work is a reasonable, sensible amount of time to recover from surgery. Some people can work from home earlier than that. Some people find they need a little bit longer. Of course, getting the calcium levels right afterwards and making sure you're on the right dose of levothyroxine is imperative. We don't tend to check the the thyroid function for a good couple of months after the operation to ensure we're not prematurely responding to old thyroxine that's sort of still in the system from before surgery. So people find it, quite tolerable surgery. Lumps in the thyroid are common. The adage is that if you were to ultrasound 50-year-old ladies, you may get up to 50% with some nodularity in the thyroid. But thyroid cancer is uncommon. But we have to cast our net wide to ensure that we're picking up all the thyroid cancers. So if you feel a new lump in the neck, it is crucial that you get an ultrasound of your thyroid for the radiologist to grade the risk of those nodules. And if there is any doubt, then you must be referred on to a thyroid surgeon like myself to take things forward. And I haven't mentioned what we really do when we see a nodule. We will look at the ultrasound and see if we're happy with that. If it looks entirely benign, you can be discharged. If there's some doubt on the ultrasound, i.e. there's a consideration this may be malignant, i.e. cancerous, then a needle biopsy will be performed. We call it cytology. And if that needle biopsy shows benign colloid cells, then again, you can be discharged. But if it shows, and about 20 to 25% of the time, it can show an inconclusive result, usually because of blood staining, it will need to be repeated. But if it shows slightly suspicious cells, then it's often the case that a hemithyroid or half thyroidectomy is needed to understand what's going on. So the takeaway point is, if you've got a new lump in the thyroid, you need to have an ultrasound by an expert so that they can understand if there is a risk or not. If in doubt, get it looked at.